Assalamu alaikum. Let's talk about cardiovascular physiology. Start with action potential. It's a tribute video from one of my listener who told me to do or make videos regarding physiology, anatomy, and those topics involved in steps. Okay, start with myocardial action potential. Before jumping into myocardial action potential, let's talk about action potential. We know that action potentials are what is action potential? It are action potential are the rapid changes in membrane potential. Action potentials are the rapid changes in the membrane potential that begins with sudden change from normal resting in normal resting potential to positive potential, then ends with almost equally rapid change back to the negative potential. So in action potential, there is rapid change in the membrane potential that begins with the sudden change from normal resting that begins with sudden change in normal resting negative membrane potential to a positive potential, then ends with almost equally rapid change back to the negative potential. So they start with negative potential, they start with minus 70, which is a normal negative resting membrane potential minus 70, then it starts depolarizing. This is the overshoot, peak overshoot, which is a positive potential, then ends with almost equally the rapid change back to the negative potential. And there are some hyperpolarization also, and this is the resting membrane potential. So in resting membrane potential, it starts with minus negative normal resting membrane potential, then it goes to the positive membrane potential, then again get back to normal negative potential. So steps of the action potential is resting stage, depolarization is stage, and repolarization stage. So their steps of action potential is resting state, resting membrane potential. This one is resting membrane potential, depolarization, and repolarization. There are three steps of action potential. Okay, now look at the myocardial action potential. There are four steps in myocardial action potential. This one is the pacemaker action potential. Okay, in myocardial action potential, what happens in here? In phase 0, this one, there is rapid upstroke and depolarization. Voltage gated channels open. In phase 0, voltage gated channel open. So in myocardial action potential, this is the phase 0 where there is voltage gated channel opens in here, phase 0, voltage gated sodium channel opens. Then phase 1, this one, phase 1, initial repolarization, inactivation of the voltage gated channel and voltage gated potassium channels begin to open in phase 1. In phase 2, plateau. In phase 2 is the plateau. This one is the phase 2. Calcium influx through the voltage gated calcium channels balances potassium efflux. So calcium influx triggers calcium release from the sarcoplasmic reticulum and myocyte contraction. There is excitation, contraction, coupling. There is excitation, contraction, coupling. Then the phase 3, this one, phase 3, rapid repolarization. There is massive efflux in rapid repolarization. There is massive efflux due to opening of voltage gated, slow, delayed rectifier potassium channel and closure of the calcium channel. In here there is closure of the calcium channel, and from here to here the effective refractory period is 200 millisecond. And we know that cardiac myocardial action potential start with negative minus 85 millivolt, and the phase for resting potential there is high potassium permeability. In phase 4 there is high potassium permeability through potassium channels. In phase 4 there is high potassium permeability in potassium channels. This is myocardial action potential. It occurs in all cardiac myocytes except for those with the SA and AV node. It occurs the myocardial action potential. It occurs in all cardiac myocytes except SA and AV node. In contrast to skeletal muscle, cardiac muscle action potential has plateau due to calcium influx and potassium efflux. Cardiac muscle contraction requires calcium influx from the ECF to induce calcium release from the sarcoplasmic reticulum, and cardiac myocytes are electrically coupled to each other by the gap junctions. So cardiac myocytes are electrically coupled by the gap junction. Okay, now pacemaker action potential. So these are the myocardial action potential. If we look here again, if we draw, this is minus 85 millivolt, phase 0. This is phase 0, influx of sodium. This is phase 0, influx of, in here depolarization happens. There is influx of sodium. There is influx of sodium and there is depolarization happens in here. And in phase 1, this one, phase 1, there is, in phase 1 there is influx of calcium. Sorry, in phase 1 there is efflux. In phase 1 there is efflux of potassium. So in phase 1 there is efflux of potassium. It is early depolarization, and then the plateau phase where there is influx of calcium, and this calcium comes from the cardiac myocyte sarcoplasmic reticulum. Influx of calcium, this is phase 2, and then again it is early depolarization. This one is rapid depolarization where there is a massive efflux of potassium. There is massive efflux of potassium. This is phase 0, phase 1, 2, 3, and then the phase 4 where there is resting potential, high potassium permeability through the potassium channels. So that is all about myocardial action potential. Now pacemaker potential. We know that pacemaker potential happens in SA and AV node. All the other All the other action potential happens in myocardial action potential, like all cardiac myocytes. So myocardial action potential occurs in all cardiac myocytes, but in SA and AV node, the pacemaker action potential happens in SA and AV node. It occurs in SA and AV node. In here there is phase 0, phase 1 and 2 are absent. There is phase 3 and phase 4. In pacemaker action potential, there is upstroke phase 0. Phase 0 is upstroke opening. In phase 0, upstroke opening of the voltage gated L-type voltage gated channel. Fast voltage gated sodium channels are permanently inactivated. Fast sodium channels, voltage gated sodium channels are permanently inactivated because of less negative resting potential of these cells, results in a slow conduction velocity that is used by AV node to prolong the transmission from the atria to the ventricle. So in phase 0 you have to remember the L-type voltage gated calcium channel opens, and there is fast voltage gated sodium channels are permanently inactivated, and phase 1 and 2 are absent in here, and phase 3 is repolarization, inactivation of the calcium channel and activation of the potassium channel and potassium efflux. And in phase 4, slow spontaneous diastolic depolarization due to IF funny current. IF funny current channels are responsible for slow mixed sodium, funny current, slow mixed sodium, inward potassium, outward current, slow mixed sodium, inward or potassium, outward current, different from inward sodium in phase 0 of ventricular action potential, accounts for automaticity of the SA and AV node. The slope of the phase 4 in the SA node determines the slope of the phase 4 in the SA node determines heart rate. Acetylcholine or adenosine decrease the heart rate of the diastolic depolarization and decrease heart rate, which catecholamines increase the depolarization and increase heart rate. Sympathetic stimulation in the chance that funny current channels are open and thus increase the heart rate. So this is all about myocardial. So this is all about pacemaker action potential. Okay. Okay. What is MP? That is membrane potential. Membrane potential is the electrical point difference across the membrane. So membrane potential is the electrical potential difference across the membrane is called membrane potential. In membrane potential there are two types of membrane potential. One is resting membrane potential, one is action potential. Resting membrane potential and action potential. In RMP, resting membrane potential is the constant electrical potential difference. Resting membrane potential is a constant electrical potential difference across the cell membrane with inside the negative relative to the outside of the cell at rest is called resting membrane potential. So it is the constant electrical potential difference across the cell membrane with the inside negative relative to the outside of the cell at rest. It's called resting membrane potential. Resting membrane potential for nerve fiber is minus 90, nerve is minus 90, neuron is minus 70, cardiac muscle fiber is 85 to 90, 85 to minus 90, and skeletal muscle is minus 80 to minus 90. Okay, now let's talk about the difference between ECF and ICF. ECF and ICF. ECF actually occupies outside the cell. ECF occupies outside the cells, and ICF occupies inside the cells. In ECF, there is high content of sodium, chloride, and calcium. And in ICF, there is high content of potassium and magnesium. And in ECF, glucose content is high, and in ICF, glucose content is low. In ECF, protein content is low, protein is low in ECF, but protein is high in ICF. And in ECF, it provides ions and nutrients to cell for maintaining cellular life. So in ECF, it provides ions and nutrients to cell for maintaining cellular life. And an ICF also provides essential fluid media inside the cell for chemical reaction. In ECF, PO2 is 35. In ICF, PO2 is 20. In ECF, PCO2 is 46, and in ICF, PCO2 is 50 millimeter of mercury. pH is 7.4 in ECF, 7.4 in ECF, and in ICF it is 7, complete 7. So ECF, it occupies outside the cell, and ICF, it occupies inside the cell. ECF has high content of sodium, chloride, and calcium, and in ICF, there is high content of potassium, magnesium, and phosphate. In ECF, glucose content is high, and in ECF glucose content is high. In ICF, glucose content is low. In ECF, protein content is low, but in ICF, protein content is high. ECF provides ions and nutrients to cells for maintaining cellular life. In ICF, it provides essential fluid media inside the cell for chemical reaction. ECF PO2 is 35, PCO2 is 46, and pH is 7.4. In ICF, PO2 is 20, PCO2 is 50, and pH is 7. Okay, now conduction pathway. In conduction pathway, there is SA node, atria, AV node, bundle of each, right to left bundle, and Purkinje fiber, then ventricle. Left ventricle divides into left anterior and left posterior fascicles. So this is SA node, AV node, then the bundle of His, a bundle of His. This is right bundle branch. This is left bundle branch, and it is further divided into left anterior fascicle. This is left anterior fascicle. This is left posterior fascicle. This is the Purkinje fiber, And from SA node, there is one bundle called Bachman bundle. Um, okay, so if we go synchronize, we have the conduction, SA node, atria, then the AV node, then the bundle of His, the right and left bundle, uh, right and left bundle branch, then Purkinje fiber, then the ventricle. Again, the left bundle branch divides into left anterior and posterior fascicle. SA node is located in the upper part of the crista terminalis near the superior vena cava opening. So it is located upper part of the crista terminalis near the SVC, superior vena cava opening. Pacemaker inherent dominance with slow phase of upstroke. This is AV node. AV node is located in the interatrial septum near the coronary sinus opening. So AV node is located in the interatrial septum near the coronary sinus opening. Blood supply usually from the blood supply of the AV node usually from the right coronary artery RCA. 100 milliseconds delay allow time for ventricular filling. So how many time is needed for ventricular filling? 100 milliseconds. And blood supply of the AV node coming from the RCA. The pacemaker rate is SA, AV, bundle of His, and Purkinje or ventricles. But the speed of conduction, these two things you need to remember. The speed of conduction is His Purkinje, atria, ventricle, and AV node. His Purkinje. The speed of conduction is His Purkinje. He parks Purkinje at Ventura at Ventura Avenue, at Ventura Avenue, like at His Purkinje, at atria, Ventura ventricle, and avenue is AV node. AV node. Okay, let's jump into two questions. Now, if you look at this question, the physiologists conducting research of the electrical properties of the heart measure action potential conduction. The results are expressed in terms of the speed of the conduction. Point point one is 0.05 millisecond, point two is 0.0 0.3 millisecond, point three is 1.1, and point four is 2.2. From the list of the location, which of the most likely which of the most likely corresponds to the order of the points? So 1, 2, 3, 4. AV, atrioventricular. So we know that AV node, a ventricular system, atrial muscle, and Purkinje system. If we remember from previous thing, like he he parks at Ventura Avenue. He parks, that means his Purkinje, whose speed of conduction is a very highest speed of conduction. He parks at the atrial muscle. Ventura is ventricular muscle, and avenue is a V node. So from 1 to 4, from lowest to highest AV node, ventricular muscle, atrial muscle, and Purkinje system. If you remember this, the fastest is Purkinje system. Fastest Purkinje system, like he parks his Purkinje at atrial muscle, ventricular muscle, and avenue slowest. Park at a ventura avenue. So uh, if we want to remember the conduction speed, AV node is 0.05 millisecond, ventricular muscle is zero point 0.3 millisecond, atrial muscle is 1.1, and Purkinje is 2.2. Purkinje is 2.2 milliseconds. Okay, if we look at this question, if we look, a 44-year-old man reports exertional shortness of breath and palpitation on examination. On examination, he has a systolic murmur. He has a systolic murmur at the left sternal border and the cardiac apex, which gets louder when he stands up. He is diagnosed with obstructive hypertrophic cardiomyopathy and paroxysmal atrial fibrillation, and is started on medication. Cardiac action potential and ventricular muscles are as fuller after administration are shown. Black curve before administration of the medication and black curve before administration of the medication and red curve after administration of the medication. So it is class 1 antiarrhythmic drug, quinidine, procainamide, disopyramide. Now in here we need to remember the CAB, CAB, like in 1C has strong uh, inhibition of the phase 0, then the intermediate is A, and B is the weakest. B is the weakest. And in a 1A, the effect of the action potential is prolonged. If you look at the effect of the action potential, the effect on action potential duration, it is prolonged. So class 1 antiarrhythmic sodium channel blocker, quinidine, procainamide, disopyramide, inhibit the phase 0 depolarization of the action potential, thereby slowing the conduction. Class A agents has a moderate potassium channel blocking activity, leading to slow the rate of the repolarization and prolongation of the action potential during cardiac myocytes. Okay. Okay, now discuss about some basics of cardiac physiology. Start with cardiac output. The amount of blood that is ejected by each ventricle per minute is called cardiac output. We know that cardiac output equal to stroke volume into heart rate. We know that stroke volume is 70 and the heart rate is near about 72, so it is approximately 5 liter per minute. So cardiac output is amount of blood that is ejected in each ventricle by each ventricle per minute. Amount of blood that is ejected by each ventricle per minute is called cardiac. Normal cardiac output is 5 to 6 liter, and the stroke volume, the amount of blood that is ejected by each ventricle during each heartbeat. So amount of blood that is ejected by each ventricle per minute is cardiac output, and during each heartbeat is stroke volume. Stroke volume is end diastolic volume minus in systolic volume, and stroke volume is affected by cap, contractility, afterload, and increased load. Stroke volume increase with contractility afterload. Stroke volume increases with contractility, increases with preload, but decreases with afterload. Stroke volume is work done by the ventricle to eject. So stroke work is work done by the ventricle to eject stroke volume. So stroke work equal to stroke volume into the mean arterial pressure. A failing heart has decreased stroke volume. Failing heart stroke volume, that means systolic and diastolic function is decreased. So stroke volume increase with contractility, increase with preload, but decreases in stroke, increased stroke volume with decrease afterload. Okay, let's talk about a very important topic called cardiac reserve. Okay, cardiac reserve is the maximum percentage. Cardiac reserve is the maximum percentage of the cardiac output. Maximum percentage of cardiac output can increase above the normal level. It's called cardiac reserve. So it is the maximum percentage that the cardiac output can increase above the normal level. It plays an important role in increasing the cardiac output during exercise, usually expressed in percentage. So cardiac reserve is expressed in percentage, and it is the maximum percentage of the cardiac output can increase above the normal. In normal value, if you look at the normal value, in young patient, cardiac reserve is 300 to 400%. In older patient, cardiac reserve is near about 200 to 250%. And for athletes, it is 500. For athletes, it is 500 to 600%. And in case of heart failure, cardiac reserve, there is no reserve. There is no cardiac reserve. So gain cardiac reserve is the maximum percentage that the cardiac output can increase above normal. The maximum percentage that the cardiac output can increase above normal is called cardiac reserve. If we want to calculate the cardiac reserve, how we can calculate cardiac reserve? We can calculate cardiac reserve by increase cardiac output and normal cardiac output into 100. How we can calculate increased cardiac output? Increased cardiac output means cardiac output in stress minus cardiac output in rest. So stress and rest. If the if you stress your heart, the cardiac output in stress it may be 25, and in normal resting cardiac output is 5, and normal cardiac output is again 5 into 100. So 20 by 5 into 100. So it is 400. So cardiac reserve is 400 in normal cases. Okay, now Effects of exercise on cardiac output. Okay, effects of exercise in cardiac output. We know that exercise increase heart rate and exercise increase cardiac output, and these cardiac output can be raised up to 700% in during exercise. What are the factors influencing the cardiac reserve? In cardiac reserves, age more in adult, like cardiac reserve is more in adult, and body surface area. If body surface area is increased, that will increase the cardiac index. If posture increase in lying and sitting, then in erect posture increase in lying and sitting, increase in lying and sitting, then in erect posture, and in exercise it increasing in exercise, and it also increase in increased body temperature. Increased body temperature directly proportional to the cardiac reserve and inversely proportional to viscosity. Increased viscosity will decrease cardiac reserve. So increased cardiac reserve will have to decrease viscosity, and there are some other factors which decreases cardiac reserve in some conditions like ischemic heart disease, primary myocardial disease, vitamin deficiency, physical damage to the myocardium, and valvular heart disease. In valvular heart disease, so acute effects. What are the acute effects of low cardiac reserve? There may be fatigue, confusion, reduced level of consciousness. There may be cold periphery, hypotension, tachycardia, rapid ready pulse, raised GBP, breathlessness, hypoxemia, oliguria, anuria, pulmonary or peripheral edema, and metabolic acidosis. Mm, We know that for cardiac output measurement, we know that in cardiac output measurement, there are some methods. There are some methods like direct and indirect method. Direct method is by using, in case of direct method is used in animals only, there by using electromagnetic or ultrasonic flowmetry. By direct by electromagnetic or ultrasonic flowmetry, and by using cardiometer, electromagnetic or ultrasonic flowmetry, and by using cardiometer. And indirect method is fixed method, indicator dilution method, fixed method, indicator dilution method, and ballistocardiographic method, pulse pressure method, and Doppler combined with echocardiography. Okay, Assalamu alaikum. Now let's talk about one of the high yield important topic, that is fixed principle. The why this principle is used, this fixed principle is used to determine the cardiac output by measuring the amount of oxygen consumed by the body in a given period of time, amount of oxygen, rate of oxygen consumption, amount of oxygen consumed by the body in a given period of time, dividing the AV difference, that means AV difference across the lungs, that means arteriovenous difference across the lung, that means arterial oxygen content minus venous oxygen content. So Fick's principle is the principle in which we measure the cardiac output. How? Measuring of the cardiac output, we measure the cardiac output, we determine the cardiac output. How? By measuring the amount of oxygen consumed by the body in a given period of time divided by arteriovenous difference across the lung. That means arterial oxygen content minus venous oxygen content. Okay, if we go for the calculation, suppose oxygen consumption by the body is 200 minus, if arterial oxygen content is 200 and venous oxygen content is 160, so 200 by 40 equal to 5 liter per minute, which is the cardiac output. We know that normal cardiac output is 5 liter per minute. If we look at this question, this 54-year-old man is being evaluated by exertional dyspnea that started. So exertional dyspnea that started 6 months ago. The patient has no associated cough or wheezing. There is no known history of heart disease in the family. ECG, chest X-ray, and exercise stress test and echocardiogram are obtained to evaluate the symptoms. He subsequently undergoes right and left cardiac catheterization. He subsequently undergoes left and right cardiac catheterization. In here, arterial oxygen content is 20 ml per 100 ml of blood. So 20 ml per 100 ml of 20 ml of oxygen per 100 ml of blood. Venous oxygen content, so arterial oxygen content minus venous oxygen content. In here, pulmonary artery diastolic pressure is 12, left ventricular diastolic pressure is 10, and mean arterial pressure is 4. In here, if we want to measure the cardiac output according to the Fick's principle law, there is arterial blood oxygen content is given, venous blood oxygen content is given, but the rate of oxygen consumption, that means oxygen consumed by the body at a given period of time, is absent. So rate of oxygen consumption is absent. Cardiac output expressed in liter per minute, calculated via cardiac output equal to stroke volume into heart rate. Cardiac output can also be determined with the pulmonary. Cardiac output can also be determined by the pulmonary artery catheter by applying pulmonary artery or Swan-Ganz catheter by applying a Fick's principle. Cardiac output, rate of oxygen consumption divided by arteriovenous oxygen difference, rate of oxygen consumption divided by arteriovenous oxygen difference. Arterial oxygen content is measured directly by the arterial blood, and mixed venous oxygen consumption is measured from the pulmonary arterial blood. So arterial oxygen content from the arterial blood and mixed venous oxygen consumed by the pulmonary arterial blood, the rate of oxygen consumption can be measured, can be determined with an oxygen meter by measuring the rate of disappearance of oxygen in exhaled air. Okay, So the fixed principle can be applied to calculate cardiac output using the rate of oxygen consumption divided by intravenous oxygen content difference. Okay, that is all about the fixed principle. Okay, what is pulses paradoxes? In inspiration, actually BP falls, but the blood pressure falls less than 10 millimeter of mercury. If during inspiration BP falls, blood pressure falls more than 10 millimeter of mercury, that is pulses paradoxes. That is pulses paradoxes. We know in pulses paradoxes there is a saying, there is a mnemonic called P code. In pulses paradoxes there is P code pericardial effusion. In pulses paradoxes there is a P code, that is pericardial effusion, obesity, pulmonary embolism. This is the pulses paradoxes P code. Pericardial effusion, obesity, asthma, COPD, and tamponade. So decrease in amplitude of systolic blood pressure more than 10 millimeter of mercury during inspiration. That is pulses paradoxus. Increase venous return during inspiration, increase right ventricular filling, and interventricular septum bows toward the left ventricle due to decreased pericardial compliance, decreased left ventricular ejection volume, and decreased systolic blood pressure. This is the pathophysiology of the pulsus paradoxus. How? Okay, there is another thing I would like to discuss, like in systolic volume, in in systolic volume is affected by aortic coarctation. In systolic volume is affected by aortic coarctation. If aortic, mm, we know that stroke volume can be measured by n diastolic volume minus n systolic volume. These n systolic volume can be affected in aortic incompetence. If aortic valve is unable to close completely, there is pressure of the left ventricle falls below the pressure of the aorta. Leaking of the blood from aorta to the ventricle. Some of the blood is regurgitated back to the left ventricle, causes volume overload, decrease force of contraction, increase in systolic volume, and which will decrease cardiac output, So, in systolic volume is affected by aortic incompetence. Okay, uh, let's talk about a very high yield topic called cardiac cycle. In cardiac cycle, there is two components. We know that cardiac cycle is cyclical repetition of the cardiac events. Cardiac cycle is a cyclical repetition of the cardiac events that occur from the beginning of the heartbeat to the beginning of the next is called cardiac cycle. Cardiac cycle time is 0.8 second and the heart rate is 75 beats per minute. In cardiac cycle, there is aortic systole and aortic diastole. Aortic systole is 0.1 second. Now, this one is the aortic systole, it is 0.1 second, and aortic diastole is zero point 0.7 second. And there is ventricular systole is 0.3 second. In ventricular systole, there is isometric volumetric contraction period, rapid ejection period, and reduced ejection period. Isovolumetric contraction, rapid ejection period, and reduced ejection period. In ventricular diastole, there is isovolumetric relaxation period, rapid filling, isovolumetric reduction period, rapid filling, fast rapid filling phase, diastasis, and last rapid filling phase. And there is another phase called protodiastolic phase. So in ventricular diastolic is 0.5 second. There is protodiastolic, isovolumetric relaxation phase, fast diastolic, filling phase, diastasis, and last rapid filling phase. Okay, if we talk about the resting heart rate decreases in athletes. Why resting heart rate is low in athletes? Can you tell me? Okay, we know that increased cardiovascular ef- efficiency allows the heart to pump a larger volume of blood with a fewer beats, resulting in lower resting heart rate. So, increased cardiovascular efficiency allows the heart to pump a larger volume of blood with a fewer beats, resulting in lower resting heart rate. And there is increased stroke volume, reducing the need of a higher heart rate to meet the body's demand. And there is improved cardiac autonomic function and enhanced increase in parasympathetic activity, which leads to lower heart rate. And in case of athletes, resting heart rate may be low when compared to the general population. A young, healthy athlete may have heart rate 30 to 40 beats per minute. The reason behind this is exercise strengthens the heart muscle, enabling to pump a larger volume of blood with increased heartbeat, so more oxygen is delivered to the muscle. Therefore, heart needs to beat few times than it would less fit person while at rest. That's why resting heart rate is low in athletes. Okay, now Now I would like to discuss about a very high yield topic called MET, that is metabolic equivalent. MET is called metabolic equivalent, one of the very high yield topic. What does MET means? The amount of oxygen consumed by the body while sitting at rest. Amount of oxygen consumed by the body while sitting at rest. It is called MET. And norm it is equal to 3.5 ml per kg body weight, 3.5 ml per kg body weight per minute. Less than 4 met and more than 4 met means less than 4 mets equal to eat, dress, use toilet, eat, dress, and use toilet, and walk indoor in the house, walk indoor in the house, and do light housework, light housework like vacuuming. And what does the format means? Climb a flight of stairs, climb a flight of stairs, climb a flight of stairs, run a short distance, run a short, climb a flight of stairs, run a short distance, and do yard work, and participate in golf, tennis, or dancing. Participate in golf, tennis, or dancing. Patient with increased risk more than one person who can perform 4 or more than 4 met can proceed to surgery. Less than 4 met, you need further evaluation for the surgery. Okay, there are some other physiology in here regarding, and there is another important physiology, Starling curve. Force of contraction is proportional to the end diastolic length of cardiac muscle fiber. So force of contraction is proportional to the end diastolic length of cardiac muscle fiber, like preload. Increased contractility with catecholamine, positive inotrope, probutamine, milrinone, digoxin. Decreased contractility with loss of functional myocardium, like myocardial infarction, beta blocker, non-dihydropyridine, calcium channel blocker, and heart failure. This is normal in exercise, normal at rest, heart failure with positive inotrope, and this one is the heart failure. Stroke volume. Force of contraction is proportional to the end diastolic length of cardiac muscle fiber. So that is all about a brief discussion about cardiac physiology. Hope you enjoyed.